A very good evening to one and all. A very warm welcome. Happy 74th Independence Day. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D community. I'm thankful to all the participants from all over the country who have taken out time and are attending this evening talk. Pharm D Community has been created with the charter to provide free webinars by eminent doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interests, facilitate and foster awareness and education in the chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Dheeraj, Kuldeep, Pooja, Vaishnavi, and Yamini for their support. I'm thankful to our speaker, Dr. Arvind Sharma sir, who is one of India's well-known neurologists. I'll hand over the session to my teammate Kuldeep, who will introduce our speaker for this evening. Over to you, Kuldeep.
Thank you. I, on behalf of Pharm D Community, once again welcome you all to this webinar on the management of patients with acute stroke. We are glad to have you all here with us today on this day of historic importance, that is 15th of August, when we, Pharm D Community, are starting with our very first webinar with one of the most renowned neurologists, Dr. Arvind Sharma sir. A very warm welcome, sir.
Thank you.
Dr. Arvind Sharma sir has done his MD and DM in neurology from PGI Chandigarh. Sir has then pursued his clinical fellowship in stroke from University of Alberta, Canada, and then fellowship in cerebrovascular ultrasonography from National University Hospitals, Singapore. Dr. Arvind Sharma sir is an ASN certified neurologist from USA. Currently, sir is working as the head in Department of Neurology and is a stroke specialist and neurosonologist at Zydus Hospital, Ahmedabad. Sir has also received several awards and recognitions. To mention, Sir has received the Best Poster Award, AOCCN, in April 2009 in South Korea. Sir has also been felicitated with the McKinney Award from American Society of Neurology in 2011 in USA. Sir has published several national and international publications and peer-reviewed scientific journals. Dr. Arvind Sharma sir is the president of the Association of National Board Accredited Institutions in Gujarat. Sir is the founder member and treasurer of the Society of Neurosonology and an executive member and treasurer of Indian Stroke Association. Sir is the scientific committee member of the Association of Physicians of Ahmedabad, and also an executive member of Academy of Neurologists of Ahmedabad. For this brief introduction, I now request our honorable speaker, Dr. Arvind Sharma sir, to please take over.
Thank you, Kuldeep, for the such a humble introduction, and thank you very much, Aishwarya, who contacted me now almost it is a month when she contacted, and I was really very excited to heard about the Pharm D community. And there is a community, you know that, right? So first of all, happy Independence Day to all of you. And this is a great day to start the auspicious day to start the initiative of such academic importance. And I think the team which you have showed will have more and more talks and more lectures on different field of medicine and other departments. I wish you all the best for the same. So I think it's now time to share the slides. Aishwarya and Kuldeep, should I do it?
Yes, sir.
Yeah. So just let me know that you are able to see that once I put that on the screen. And
yes, sir. It's visible, sir.
Yeah. So it's visible, right? So you are able to see that. Okay.
Yes, sir.
Okay. So thank you very much. So I'll first of all, I just see that if I go to the next slide very easily or not. I'm pushing the next slide, but I'm not. Yeah, I'm able to move it. So thank you to the Pharm D community, Aishwarya, Kuldeep, and I don't remember the name. My frontal lobe memory is not very good, but thank you to all of you who are here to participate in this talk. I'll take you towards the journey towards the acute stroke management in the patient who are coming with the acute stroke, right? So before I do that, Ashwarya and Kuldeep, if you are not able to see the slides or any problem in audio, please let me know. Is it okay?
Sure, sir.
Yeah. So one invisible organism had shut the whole world, and during the lockdown, this is the famous saying when I did a lot of presentation during the lockdown, that what the lockdown does to you will not depend on the virus; it depends on what you are. And that is the initiative what the Pharm D community has shown for this academic activity, and that is the really a nice one. So as we move towards the acute stroke management, before we do that, we should know something basic. As I know that you are learning about the all the pharmacology and the medicine part, and really when I worked as a fellow at Canada and worked at Canada, the pharmacy people are so much important for us to guide us when we are doing the rounds in stroke fellowship. So when we take about the definition of stroke, we should know that how it differs, because a lot of people still as a doctor and different communities still feel that stroke is happening in heart. So to make it clear that stroke happens in brain. So the rapid loss of brain function due to disturbance in the blood supply to the brain, in that 85% are ischemic. You can see here there is a clot there lying up which is blocking the artery. There is a lack of blood flow causing the blockage. It can be embolic or it can be thrombotic. And the 15% are due to the leakage of vessel. Because of the high blood pressure, the vessel can break and it can burst and cause the hemorrhage. And the most common cause, as you all of know about it, is hemorrhage. So if we go further, this is what, when we are doing our medical school, on the dissection table, we see these pictures of the sections of the brain. And of the top one, if you can see my arrow, is the thrombosis. Because of the artery thrombosis, this is the area of wet shade which has been affected because of infarct. The embolism also affect in the certain area. You can see that. This is the embolic. And this is what every surgeon is afraid of when there is a cardiac arrest or hypoxia. There can be a damage in the area of the watershed area. There are arteries supplying to the brain like anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery, anterior, middle, and the posterior. So the area which is damaged is the watershed area between the two arteries, that is the hypoxic damage. And here you see the red one is the blood at the topmost, which is the hemorrhage, because of the subarachnoid hemorrhage, because there is, you see the vessel, the artery which is going, which get ruptured because there is a balloon formation which is known as aneurysm. And if it is a high blood pressure, it ruptures like it's a thunderclap headache, which it is present as. And the next down picture which you see of hemorrhage is the basal ganglion hemorrhage, which is typical because of the hypertensive bleed. So why it is important to manage acute stroke? This is why what the slide you are seeing on your screen is important, because time is brain and time matters. Why? You see on one on your left side of your screen, there is a CT scan which is showing a hypotense area on the one side of the brain, which shows that it is the damaged area of the brain. And that is a CT scan. And the lower down, there is an MRI image where the white you see is the damaged area. So you see how the neurons, synapses, myelinated fibers are damaged in 1 second. You can see 32,000, 1.9 million in 1 minute, and 1 hour, 120 million fibers are damaged, neurons are damaged. So you see, if those damage occur, how your age accelerated because of that damage. For 1 hour, you lose 3.6 years. And for the average stroke, how much you lose, you can see, and how much you are not able to do your work because the area which is damaged in the brain, that will, you will lose the function. It can be language, it can be arm, it can be leg, it can be speech, it can be facial movements. So as we go further, 1 of 4 of us will have a stroke. Don't be the one. So you have to have the all the primary preventions like a good diet, you manage your blood pressure, you manage your diabetic, and it is all has gone. There is no age bar, no gender bar. Everyone above 18 years has to check their blood pressure. You all know about it, all are aware about those things of a good lifestyle. It's not to preach, it is to follow those guidelines which has been written. So there is a quiz, but I will not do it like this. You can guess. right? I'll not ask you guys, but how many people die per hour from stroke in India is 15. And these are the questionnaire which we have given to the layman who came to our hospital, and you will be surprised. These are the questions you all know because you are doing a you are in the area of the medical field, so you all know about it. But you ask these questions to the people who are coming to the hospital, or you meet as a layperson. Can stroke affect any regardless of age and gender? There are people, 25% who are answering in a different way. There are people who don't know that stroke is reversible and treatable, and there is a golden window of acute stroke that is 4.3 hours. Is stroke is reversible and treatable? It is reversible and treatable. What are the symptoms of the stroke? All of the above. What are the not risk factor of the stroke? Diet and high fruit vegetables is good, but the risk factor is only other three are the risk factors which are modifiable. There are modifiable risk factors and the non-modifiable risk factors. You cannot manage your age, you cannot manage your gender, you cannot manage your family history. Those are non-modifiable factors. But the modifiable factors like high blood pressure, smoking, uncontrolled diabetes, good diet, these you can change. They are modifiable, and that depends on you and the people who are taking as a primary prevention. But the last one, which organ does stroke affect? I tell you, there were a lot of people who have written kidney, heart, and lung, and we were surprised. So we know that the awareness for stroke is still very low. And I will request you, when you have this lecture, you should, when you have this talk, you should talk to the people about stroke, that it happens in the brain. So this is what the fascinating picture as a stroke neurologist I love when I deal stroke. Because heart, there are three vessels. There is a LAD, there is left circumflex, and the RCA. But brain is a very complicated structure. This is the base side of the brain where you can see the circle of Willis. These are the two vertebral arteries forming the basilar artery, and they come like a leaf to form a posterior cerebral artery. They are connected to the anterior circulation, which is the major artery, that is the middle cerebral artery, which is supplying two-thirds of the brain. And you can see in front there is a anterior cerebral artery. So how the arteries go up to the brain? They go through the neck. And you have to know that there are the two major arteries in the neck. That is the internal carotid artery, and another which is coming out of the subclavian, going as a vertebral artery through the vertebra to the brain, and which is forming the circumvallus when they go to the brain. So you have to know that external carotid artery and internal carotid artery, from the common carotid artery, when they divide at the carotid bulb, the external carotid artery can have the branches, but internal carotid artery doesn't have any branches in neck. It's the first artery which gives the branch is the ophthalmic artery. This is what you should know when we are dealing with this stroke. This is with the anatomy. And as you are the medical people, you come a lot of across about the CT scan and MRI. Nowadays, it is not the brain. You show the CT, you show a CT or MRI to the people to let know their blood supply. And what is I'm going to do, you will take you through that, through the MRI. This is the axial image. You can see this purple area. This is the ACA. This is the whole middle cerebral artery. And you can see this is the area supplied by the posterior cerebral artery. And similar, because MRI has the axial, sagittal, and then the coronal image. You can see how the yellow one is the anterior cerebral artery, then go to the pink one, which is the major chunk of the anterior circulation, that is the middle cerebral artery, and the lower down, there is a posterior circulation, that is the posterior cerebral artery. And same is in the coronal images. Burden, if you see this slide, I want to tell you, don't go to the 5.5 million death across world. But I will emphasize more on the disability, daily of active living by the patient after suffering the stroke. That is 116.4 million people are disabled. That is, if they are young, their whole family, the whole socioeconomic thing is gone. So I know as a Pharm D community, I'll come to the treatment part, which you are waiting for, but this is what the gravity you should know across the globe. And this is what the Indian perspective is. It's the second commonest cause of death in India. You know what WHO has said, 1.4 to 1.6 million cases of the new acute stroke happens. And you see the count in second. One stroke happens in every 40 seconds and one stroke death in every 4 minutes. That is what have to prevent, and more of the disability. If we give the acute treatment on time to the patient within 24 hours, it is not only 4.5 hours, within 24 hours. If you give the treatment to the patient benefits. And here the stroke prevalence, we have 80% of ischemic stroke, and we have slightly high amount of hemorrhage at our place. And if you see, uh, there are perception which are really as a myth and reality, and it's still with the, even with the physician, not even the lay people. You see, these are the, if you see the slide well, many people that think that a stroke is not preventable. I tell you, 80% of the stroke are preventable if you do the primary prevention and if you do with the medication as a secondary prevention. Stroke cannot be treated. Stroke is very much treatable and reversible. And it has been said that it is only an elderly. I'm sorry for that. Stroke can happen to anyone. In young age, we have seen a lot of people coming, and even during the COVID times, you know that there are a lot of literature which is coming up. Have people are having this stroke in the young age, and they are suffering from stroke because of COVID, because they have a thromboembolic phenomena, and there is recommendation of aspirin and heparin in such patients. Stroke happens in heart? Not at all. It's a brain attack. And the most important thing when you talk about the recovery, it is not the 6 months. We have seen people recovering. Don't get disheartened. Good OT and PT, physical therapy and occupational therapy, and good guided medical treatment after the stroke help the patient to recover lifelong. That is known as neuronal plasticity, which is very important. Now, these are the stroke symptoms: sudden trouble walking and dizziness and loss of balance or coordination. That is the posterior circulation. And you heard about the fast, be fast, balance, eye movement disorder. Then F is the face, where is the facial deviation. A is the arm or leg, which is going down. S is the speech, where you have a slurring of speech, or there is a language problem where patient cannot understand about it. And there is a numbness or weakness of one whole half of the body, which is the most common, that is known as the hemiplasia or hemiparesis. There can be a sudden severe headache, and there can be a hemorrhage in the brain. There is sudden trouble seeing in the eye, where people go to the ophthalmologist. But I will talk to you about one of the symptoms which is there on the top left. That is the sudden confusion, trouble speaking and understanding. I'll give you a very beautiful example for that, how stroke are misinterpreted by even the medical field. There was one CEO of age of 36 years, and he was very obese. So what happened? One day he has suddenly trouble in speaking, and when he was asked that what is your name, he used to say that my name is that I live at Prahlad Nagar in Ahmedabad. So, and when you ask what is your job, so my job is, he was a CEO of one of the software companies. So he says that my job is to deal with computers and the softwares, and but he was not able to, what is your company name? He's not able to tell his company name. So he was circumloculating to that part. So his colleagues, as he was CEO, his family members thought he is in the utter pressure. So they took him to the psychiatrist. The psychiatrist given him the medication, which is the tension relieving. Clonazepam was the drug given to him. Next day, again went to the another psychiatrist because he was not getting the relief. Then he came to the emergency of our hospital, where the doctor of the emergency was seeing him and asked, we were there on the call, can you see this patient? Because he went to the two psychiatrists, and he's a CEO and a lot of pressure, so he's having a speaking problem. So when we saw him and we asked him, he was circumliculating, and in our language, it was a jargon speech. He was very fluent, and it is called in our language as aphasia. When we did his imaging, we found, in fact, a damaged area in the parietal area of the brain. So we diagnosed him as a stroke, and that is the typical Wernicke's aphasia, where you are fluent, but you are not able to answer the question right. You this, they will not tell it is a watch. They will say this is for seeing the time, but they will not come to the exact pinpoint thing. It is a pen or what, right? So we diagnosed him, but things doesn't finish here. We found that his heart has been some problem, and we treated him. But things doesn't end here. He told that I am a CEO, I cannot join because I'm not confident now talking to the people when they say I understand them, but I'm not able to communicate them in a proper sense. So there comes the role where you have done the treatment in the form of aspirin, clopidogrel, statin given to him to stabilize the plaque, and everything was given. But there comes the role of speech therapy. He underwent a speech therapy for 3 months. After that, he regained that confidence, and he's gradually, because as we treat the stroke patient, it is not a magic bullet. Patient will not get all right. We take a 3 months period that is known as, I will tell you in the further slide, that is a modified ranking scale, which we see. And when we see after 3 months, not on the day one. So after 3 months, he recovered so much that he joined his company again, and he's still very healthy with his family. And he went to the Vaishno Devi, and subsequently he was good. Ashwarya, I'm muted, I think. Hello.
No, sir, you're audible, sir.
Okay, I'm audible. So here we came with a symptom. If you tell time is short, I will cut short my talk. Is all okay?
Sir, there's no time limit as such,
Okay,
sir.
fair enough. So as thank you very much, Ashwarya. So as we go further, if you see, these are the anterior circulation symptoms: occasional headache. There can be homonymous visual field defect. There can be language defect, which I discussed with you about the young CEO. Hemiparesis, you can see the sensory locks, which is shown in black. And sometimes patient can go in a coma if it is a big clot and big infarct. So posterior circulation stroke is slightly variable, where it limits it as a variable because it's a very, if you see, there are a lot of arteries in the posterior circulation, which limits, and it is known as a chota magaj. If it is not of your era, Nana Patekar is very, and he used to tap his back as called as a chota magaj, right? And it is a very complicated area where stroke syndromes don't present like you as a bookish. They present in a different aspect. They can be incomplete, atypical, they merge one to another. You can see the arteries, which I've shown you as a both vertebral arteries forming a basilar artery, then forming a posterior cerebral artery. So these are the symptoms of posterior circulation, where you can go in coma. There can be a vertiginous feeling. So I tell you, 25% of the vertigo above the age of 40 are not peripheral. So the ENT also send it to a neurologist to rule out a central cause, because those vertigos are sometimes dangerous. So if you see a patient with hypertension, diabetics more than 40 years, you should send that patient to a neurologist to know that this vertigo is not simple, not peripheral, it can be central. And you can see the other thing, a patient can go into coma if the basilar artery, which is a very big artery, if get occluded. I want to give emphasis to this slide because, as you all know about the heart attacks, you have heard about unstable angina. So TIA, I consider equivalent to the unstable angina. TIA is a transient ischemic attack, that is a mini stroke. That, like, you have a one arm, one leg, and the facial weakness for 5 minutes, and it improved. So they are the warning signs of stroke. So what the physician, we all in this world are very positive, like that corona will go away in April, then in May, then in August. Now all are praying that there was a some indication that it will go away in winter, then it will have a recycle. No, no, no. The astrologer has said it will go away. So we are positive people. So whenever that we have a symptom of stroke, we are very positive that it is a numbness or a weakness in hand, it will go away. Even the physician says that. But I tell you, if you see the percentage, the TIA, the 1/3 of the TIA convert into a major stroke. So don't take them lightly. They are like unstable angina of the heart. Get yourself checked why you had a TIA. You are not lucky, but you had the symptom of stroke, which resolved by itself because you have in your body, you all are a Pharm D community. You know that we have TPA, that is tissue plasminogen activator, in our body, which can dissolve it, right? So the 90 days risk of the TIA is 70% and greatest in the first week. So we call it as a take immediate action. How? You do a echo for the heart or TMT, you do a carotid Doppler for the neck, and you can do a imaging for the brain to know that it has not left a permanent mark in the brain, where you use CT scan and MRI. So what are the facts about stroke? People don't recognize the symptom. They have a denial. Oh, I am a 19-year-old, 20-year-old. I don't smoke. Don't have diabetes, don't have hypertension. Why I will have a stroke, right? So people think that I slept like this, so my hand is weak. So that should not be. Think nothing can be done. That is the biggest mistake. Worry about cost. I tell you, if you see our corporate where I work, I even work at a civil hospital where the drug is free. That is the Alteplase, which is a drug of choice for stroke, which we'll discuss further, is free. If you go in the corporate, it is less than the angioplasty what you do for the heart. Think symptoms will disappear. It is a very positive thinking, but you have to go to the hospital and fear of the hospital because nothing can be done. Now, coming to the subtypes of the stroke, where we'll talk about treatment of these strokes. So subtypes are very important. We discussed about the 15%, but we'll divide the 85% of the stroke. In that, there are atherosclerotic because of the artery, which is as it age, there is a deposit of the plaque there. Small vessel disease in the brain. Cardioembolic stroke are 20%. When the heart pump the blood to the brain, 20 to 25%, they can have a clot and they can shoot up in the brain if you have a cardiac disease. But what we want to reduce as a mechanism of stroke is the cryptogenic stroke, where we want to know the mechanism of stroke. So these two slides I always show my resident, and I will show it to you, and which are very important as a case wise. A 60-year-old gentleman, irregular treatment, developed sudden onset of headache and vomiting, and the blood pressure was 180, 110, presented with the hemiparesis. There was arm and leg weakness, and he was drowsy. So it is a point when I was also risen to raise a hand and tell that, oh, it's a bleed. But I tell you, which there is a ischemic stroke, there is no blood. Blood is always white in the brain. You can see there is a hyperdense area on the right side of the brain, which is a major malignant MCA infarction. So the first humble request to all Pharm D community that you should spread never guess type of stroke, because CT scan is of the brain for stroke is equivalent to ECG of the heart. So when you go to a cardiologist, he do ECG. For neurologists, for stroke specialists, it is CT brain. So send a patient where there is a CT scan, just like ECG for heart, when you want to treat a stroke, because 15% can be hemorrhage. So you cannot give any blood thinner to those patients who are coming with the hemiparesis. Both will present with the same, and you cannot harm the patient who have the bleed. The second patient, he has a blood pressure normal, 140/80, because he decompensated with hypertension, same age, presented with hemiparesis and drowsiness. He can have this bleed. You can see the white area in the brain, which is a big bleed. And if you see the midline, it is shifting the brain on the other side, which is causing the midline shift. So the second humble request is never predict type of stroke and never give aspirin before CT brain. It's a tendency for the heart that you give a sorbitrate and you give an aspirin or 4-clopidogrel to the heart patient. Please don't do for a stroke patient. Do a CT scan, which is equivalent to ECG in stroke, and identify what type of the stroke it is, and then only give the treatment. So early you treat and the greater is the benefit. You know, those who are in the research in Pharm D, they know number needed to treat. If you give a recombinant tissue plasminogen activator, which is the Alteplase drug of choice for treating the acute stroke symptoms, if it is given less than 90 minutes of the onset to the symptom, if you give that IV drug, which we'll talk about the doses, the number needed to treat is 4 to 5. As you go lower down to 4.5 hours, the number needed to treat increases. So those who come early, and so that's why you have to say that if there's a golden window of 4.5 hours, you have to reach early, and doctor cannot sit like this, oh abhi to 4.5 ghante hai, hum baith sakte hain. It is not like ASAP. You have to give the drug to the patient, where you give the bolus. Bolus is very important. We will discuss about it. So what we do when the patient come to our emergency room, we do an evaluation scale, and we have a checklist in the stroke care. So this is what we do at our place. Most important mimic, if you see as a stroke mimic, is hypoglycemia. So our vitals are pulse, blood pressure, temperature, saturation, and blood sugar. You can see blood sugar at the top. If it is a hypoglycemia, it can present any type of symptom of stroke or unconsciousness. So you have to take care of it. If you give glucose to them, they totally reverse in their phenomena, that is hypoglycemia. This is the protocol we follow, the exact time of onset. If you see the emergency chart, the stroke team notified, we have a stroke code at our place that is known as the code white at our place. The call goes to everyone in the hospital, and the NIHSS, which is the stroke severity scale, the National Institute Health Stroke Scale, which I'll discuss in the next 2 slides, that is done, and the uncontrolled hypertension is treated with the drugs. We'll discuss about it. And this is how the sheet is maintained. We take a procedure consent form. We explain that the IV TPA, the recombinant tissue plasminogen activator, which is given to you, is more benefit than the harm, 6.4% of the chances of hemorrhage. And if it is a major occlusion, then we shift the patient as a tertiary care to our cath lab. But I tell you, if you are sitting at the periphery where there is no cath lab, still you can thrombolize those patients as a stroke. You only need a CT scan to treat the stroke. There is a nursing acute stroke chart which you can see. What are the stroke scale we are dealing with when you are treating an acute stroke? So these are the scale. MRS is the modified ranking scale, which we do for a disability after 3 months. And then there is a NIHSS, that is the National Institute Health Stroke Scale, BI Barthel Index, and there is a Glasgow Outcome Scale. These are the various scale. We use NIHSS scale. You can go and you can certify if you want to do research, as we are doing research in stroke. As you guys are totally in research, you guys will go in a clinical trials where you will ask, that is the NIHSS certified people can only do the stroke treatment and the research. And these are the 42-point scale where you see level of consciousness, best gaze, visual field, facial paralysis, best motor response, limb ataxia, sensory, best language. If you go on online, you can get certified to this NIHSS. And outcome scale, very important. What we want our patient, as we're discussing about that aphasia, the CEO, we want those patients from 0 to 2. That is good outcome. No symptom, no significant disability despite symptoms, and slight disability, that is 2. But we don't want our patient to have the moderate disability, moderate severe disability, and no one want severe disability and death, that is 6. So we want our modified ranking scale after 3 months, 0 to 2. So what are the stroke mimics? As I told you about hypoglycemia, they are seizures, systemic infection, migrainous headaches. Sometimes if they are severe, they can present with hemiplegia, metabolic acidosis like low sodium, and sometimes I'll not deny that many somatoform conversion disorder, they come with the facial weakness and 0 by 5 power, young male or female. We have even given thrombolytic drug to them because they so mimic to the stroke, and initial for golden hour, the CT scan is normal. So that is why MRI is helpful for such patient. Syncope can present like this. Tumors can present like this. Acute confusional stage. These are all differential diagnoses for stroke. The simple peripheral vertigo, as we discussed, I have written that 25. I've already told you 25% patient with acute vestibular syndrome may have stroke, as you can see on the slide. Dementia, encephalitis, and epidural hematomas. So what evaluation when the emergency you come? You first do glucose, you do ECG, you do saturation, you do the platelet, which are very important to give the blood thinner in the form of RTPA, because we need a platelet function more than 1 lakh to give the thrombolytic. We need the INR less than 1.7 for such patients. So we do the PT and INR also, which is very important in such patients. So role of brain imaging, we at our hospital, we have a protocol of CT brain and the CT angio to know about the occlusion also. Many hospitals where there are MRI, they are doing it, but MRI is difficult to do and it is time consuming. So we use a CT and CT angio protocol where we know the clot and we dissolve the clot. So what are the pathophysiology of ischemic stroke? I will take you to that. I will not go much into it in the technical or the biochemical part of it. So you must understand that rich anastomotic connections between the carotid, the anterior circulation, and the posterior circulation vertebral artery. If you have a powerful collateral system, then you compensate for the occlusion. If good collateral system, you have a better result when you treat the stroke. If it is a bad collateral system, so it has been said how the collateral system are developed. When there is an anterior circulation and the posterior circulation, the the penumbra, which is very important when we are treating the stroke, the collaterals are developed with a good physical activity right from the birth. So it is not like that you have a blood pressure and diabetes at the age of 40 or 45, then you start exercising. You have seen many people after, ab to mujhe diabetes ho gaya, mujhe blood pressure ho gaya, now I will exercise. So I tell you, these collaterals are developed when you are born and start exercising when you are young, and it is a continuous process of life. So you have heard कि पढ़ोगे लिखोगे बनोगे नवाब, खेलोगे कूदोगे बनोगे खराब. This is what the saying when we have grown up at our age, and the elderlies have this saying that always say. But I tell you to develop your collaterals, and which I've seen even our prime minister has that saying. Right now the new thing has developed. पढ़ोगे लिखोगे बनोगे नवाब, agree. पर खेलोगे कूदोगे बनोगे लाजवाब. Loss of in the sense you will develop collateral and good collaterals, and if you develop a stroke also, you will be wonderful. So I will take to that concept, that is ischemic penumbra. That is the area where there is a slight things are going on, slight blood flow is going on, and how you save it. So you go down and look at the picture down. I'll show you in that. There is a core where there is as soon as you have a stroke, there is a damaged area of the brain, which you can see as a central core in that cartoon, which is you can see down. And there is a surrounding area, which is the penumbra. That is, if you see at a 1 hour of onset. If you go further at a 3 hours, that core is increased because you have not treated the patient, and you're losing the area where there is still the blood supply is, that is known as penumbra. But at 6 hours, it's the total eclipse, and you totally lose that area. And that is why that golden window is there. It is not because of the hemorrhage, that hemorrhage will happen. It is that area which you lose, which you can save when there is acute stroke. I'll show you with the cartoon. If you see there is a black dot, it is opposite side, there is a full middle cerebral artery, which you can see. But here where there is a damages, there is no supply further. And you see there is an infarct form. And this is that tissue at risk, which you can save. And if you treat such patient with thrombolytic drug at that point of time, you will save the area of the at tissue risk, right? So that is why the penumbra concept is very important. And that is why the early treatment is important. It is not uh, because of the hemorrhage, it is because that area is damaged. And you can see this is the ischemic brain edema, which has formed if you don't treat the patient. So it is, we all are clinical neurologists, we all deal with, you are as a Pharm D community, you are clinicians where you deal with it, but there are now scans which are giving a lot of information that are becoming an MRI logist and CT logist, but trust me, I'm a neurologist. So if we go further, what we target 4Ps, it is the parenchyma of the brain, the pipes, all the pipes which are going, the perfusion of those area of the brain, and the penumbra. These are the 4Ps when we are targeting, when we are giving the blood thinners to them. I will show you some early signs of acute stroke on brain, that is hypoattenuation in the brain tissue, the lentiform nucleus obscuration. I will show you one by one on the scan, dense MCA, insular ribbon, what it is, and loss of sulcal effacement when you are on round with the physician or the neurologist as a pharmacist on you are doing a research. So you will be well versed with that. So this is how the area is divided in the brain. This is one section and this is another cartoon. We do an aspect score to look for the damage area, like the M1, M2, M3, and the codate and the internal capsule. So if you go further, you see the insular ripple sign here, and you see the obscuration of the lentiform nucleus. And if you go further, this is on the stroke window where you see the damage area more dark in there. So when you have an MCA, you have a damaged area on the MCA platform. And this is how the artery is not seen on that area. And the other side, you can see the whole artery, which is preserved. And this is what the blockage is, which you're going to open by giving the drug. And this is what the hyperdense MCA sign, this is M1, and this is what M2 is in MCA. And these are the stroke mimics, which can be very devastating as a hemorrhage. And this is again further, this is a subdural hematoma. If you see, this is the blood in the brain. But we'll not discuss, we'll go further for your knowledge to discuss more about the one of the patient. So we'll discuss one of the patient for you as a clinical scenario when we'll discuss the drug, like if you have giving a TPA to such patients, what happened? It was a 78-year-old lady, right-sided weakness, upper limb and lower limb with 2/5, aphasic, not able to speak. NIHSS severity from 1 to 42. If it is 10, it is moderately severe. MRI brain with MRA done within an hour. Because she was a neurophysiotherapist, she done the MRI within an hour and presented to door to our place at 2.5 hours. If you see, MRI is not showing anything, but you see the opposite side, this vessel is present, but the ICA and MC are totally gone, as I have initially showed you. So this patient was door to needle for TPA, the thrombolytic drug, which was given in 3 hours. Patient improved in 3 days and went walking, and physical therapy. And we put on the single antiplatelet. But things are not over here. This is what the stroke was developed. If the ICA is occluded, the whole half side of the brain should have gone. So you have given the timely drug to the 78-year-old lady, and you have saved so much of the area, which was the penumbra. But after, if you see, this patient has presented after 3 weeks with the mild symptoms, and her the granddaughter was a neurophysiotherapist. She identified again, and went for an MRI again. And there was a small clot higher up in the parietal region. And we took a liberty of angio, and this is what happened when you give a thrombolytic drug, TP on time. You can see that partially ICA and MCA were open, and that is why she improved. That is why she improved. Patient was put on double antiplatelet, and we did investigate for the recurrent stroke. We did a Holter, and we found that Holter was normal. So this is how you prognosticate patient, and you add a drug when there is another stroke. First, it was a single antiplatelet. You try to identify the cause. Is it the rhythm problem? Why you want to give the drug? So this is how you treat the patient. Stroke neurologist, what is the weekend for them? Those who are working in acute emergency, there is nothing like weekend and nothing like the holiday. It is like you are playing with the fire in the thing, and there is a work-life balance, or you can say it's a spouse balance nowadays if you don't want to keep a gender bias. So if you see the multimodal imaging which we do, it is what we do. We do different reperfusion strategies, ischemic penumbra. We do MRI and CT for them. And this is how we do the CT angio and MR angio for those patients, where we see the tissue status, we do the perfusion status, and we see the vessel status. As we discuss about the 4Ps, right? There is a vessel status, that are the pipes, perfusion, and the tissue, that was the parenchyma, and the fourth is the penumbra. So we do all these perfusion studies, but most common which we do is the CT scan and the CT angiography when patient come to us at an acute stroke. So what is the CT scan gives to us? Is there is a hemorrhage? If there is no hemorrhage, we thrombolize. If there is an intravascular thrombosis, target for thrombolysis. Core is critically irreversible, CTP. You do a perfusion, know about the penumbra, and you do an intervention for such patients. So if we go further, now coming to the medical part, what are the drugs available to treat such patient? That is the stroke management. It is not like the cardiologist, a single man job. Stroke management is a team where all the people like stroke neurologist, neurosurgeon, neuroradiologist, intensivist, and the neurorehabilitation come together to treat such patient. As I told you that for 36-year-old CEO who was treated by speech therapy subsequently, and the many people played part in his treatment, even the drug has played the part. So it is the stroke unit which is important, and it's a team effort. Whatever you do, you can see on the, we do whatever we do it together. It is very important. If you go 20 years to 25 years back, it was 1995 where the acute stroke management treatment has changed. And I tell you, when I came from Canada, there was one of the senior cardiologists, and I was talking about 2008. 1995 the drug has come. Even in India, when I did, we used to do a lot of thrombolysis at where I did my fellowship. When I came to India, the people at 2008 were also very reluctant to give the thrombolytic drug. There was not much awareness, and they think there is no advantage of giving it. Once the paralysis is done, it's done, nothing can be done. So the cardiologist said, "Kya karoge stroke ka management? What you will do with the stroke management? Put one pipe up and one pipe down, the stroke treatment is done." But I tell you, there are a lot of advances which are happening only in two areas. It is the oncology and stroke. There are a lot of, even neuromedicine, a lot of medications which are coming, and a lot of advances are coming. And it's a hell from 2008 till day. There are a lot of management which has come, and there are a lot of advent of reperfusion strategies for the stroke that has developed. Intravenous pharmacological reperfusion strategies, novel fibrinolytic agent, the glycoprotein has been tried, combination therapies are tried, directly the drug from the catheter has gone to intraarterial. Then the 2015 came where directly they go inside the artery and take out the clot, just like the cardiac, and the multimodal imaging. I just spoken to you about it, where the 78-year-old lady, how it was treated with the MR angio and MRI. So these are the intravenous pharmacological reperfusion strategy. You can see the graph, you can see a table where it has been shown. And these are all the drugs which have come in picture, and Alteplase, desmetoplase, tenecteplase, retiplase, plasmin, and microplasmin. And you see the picture on the other side. Extrinsically, we are giving streptokinase, urokinase, and RTPA. Intrinsically, we have TPA with us. So those TIAs which recover by itself, they recover because of their intrinsic TIA, and they don't complete at the stroke. but you need to investigate why they have a tendency of developing a stroke. And these are activated, so plasminogen is converted to plasmin and the fibrin is fragmented. And for if there is a much of the bleeding, you have seen in gynae, they use a tranexamic acid and aproctenin a lot as an inhibitor. So the only drug till date FDA has approved is the Alteplase, but the very potent and very promising drug which is coming in the market, which still need a lot of trials going on that behalf, is the tenecteplase. So many people ask, and as a Pharm D community, you can also ask, when streptokinase work for cardiac, and they are using a right to left in cardiac people, why it is not working in stroke? It is same the vascular structure which is going to the brain. So what the neurologist and the community as a neurology has done a mistake. They use this streptokinase in MAST-T, MAST-I, and ASK trial in the same doses as cardiac as brain. So when they use the cardiac doses, there are a lot of intracranial bleed, intracranial hemorrhage because of that drug, because that is a blood thinner. So that is why the trial was stopped. But this drug, streptokinase, I tell you, the researchers in the Pharm D community and the neurology and stroke neurologists, they are testing this drug again because it's a cheap drug and it is helpful for the Southeast Asia and the North Africa community, where as the assist trial is still again tried to be brought back, it can be used in the stroke or not. But this is what the trials for the tissue plasminogen activator, that is the recombinant tissue plasminogen activator, that is Alteplase. The pivotal trial which was done, that is the NINS trial, you should remember, whenever you are reading about it, the therapeutic window was 3 hours at the time. Then the ECAS 1, 2, 3 trials have come, and Atlantis and JAC. Japanese thought that we Asians are different. Why 0.9 milligram is to be used? They use the 0.6 milligram of RTPA. And ECAS 3 in 2008 in NEGM, very reputed journal, therapeutic window was extended to 4.5 hours because of that penumbra. So thrombolysis as an IV remain as a very effective proven drug treatment in acute stroke. So this was the trial in 1995. Landmark trial is still the doses are same. The RTPA is used in 0.9 milligram per kg. We has just treated few days back. Weight of that patient was 140 kg, but we cannot use more than 90 milligram of the total dose of RTPA. 10% is given bolus, and 90% is the continuous infusion over the 60 minutes. And when it was seen in the trial, if you see the lower image, lower where have marked it, for every 100 patients treated, 32 have a better outcome, only 3 have a worse outcome. And the symptomatic hemorrhage was found in 6.4% of the people. So there was a lot of business in this. If you see a good business, if you see in that perspective, a lot of patient has been treated, and only 4 to 6 patients are needed to have a good outcome if you treat them in a good time window. This slide is jumbled up. I'm sorry for that, but 0 to 90 minutes, you see the odd ratio is maximum where you can treat the patient and you can get the maximum benefit. So in this, I want to make your concentration the lowermost. The pool analysis suggested that as soon as possible, you treat the patient with this TPA. The ischemic penumbra is preserved. It is not the hemorrhage. It is not the parenchymal hematoma, which is important. And I will tell you the importance of thymus brain by this case. He was an orthopedic surgeon, came from US to Ahmedabad. He was traveling to Abu next day, and you see at the 2 a.m. He reached to the emergency, and he had the symptoms at 2 a.m. of 0 by 5, right upper limb and lower limb was totally paralyzed, and reached to the hospital emergency at 2:30 a.m. CT was not showing any changes. Aspect score was 10. You can see the CT, and there was a plaque in the neck. And if we calculate the doses, it is very nicely calculated, 0.9 milligram per kg. This is what the dosing chart comes. If 50 kg, 45, 4.5 milligram is given the bolus. Even if it is greater than 100 kg, you give only 90 milligram. So such patient, when treated, this is how, before we go to that patient, I will show you, I kept this slide specifically for you, how the Alteplase is being mixed. So you don't shake, because it is a proteinous material, it will damage. So it is taken with the diluent, and it directly you pour it, and you don't move it much, and you take it and give the bolus 10%. And this is what this, you don't shake it because you will denature there. So stroke happen at 2 a.m., reach emergency at 2:30. bolus was started at 2:55. Because he was the orthopedic surgeon, he notified us. So we were all ready for him at the time where all the emergencies are paralyzed across world, I tell you. So door to needle time was 25 minutes and onset to needle was 55 minutes. And patient went walking with 1,08,000 bill and with only mild pulmonary, and he was walked out of the hospital. So this is how you make the difference. This is what the World Stroke Organization says you: 0 minute, 10 minutes you do all the evaluation, you notify the stroke team, 25 within 25 minutes you do a CT scan, you do all the lab work. It's a coordination of all people, and in the 16 minutes you needle that drug to those patients. So it's a famous saying, right? By the Einstein, time is brain, time lost is brain lost. When you sit with a nice girl for 2 hours, it seems like 2 minutes. When you sit on a hot stove for 2 minutes, it seems like 2 hours, because that's what relativity is. So this is very important. So we'll not go in detail because already we have taken so much of time of yours. And before you leave, I want to give you the 4 steps of how you give the Alteplase treatment. Ashwarya, another 5 minutes is okay? Kuldeep?
Yes, sir, it will do,
You
sir.
are all fine, or you're getting bored, so I can stop it if you want, right?
No, sir. Actually, it's a very interesting session, and
Okay, so
I'm
if you
enjoying
go to
listening.
the, thank you very much, and all of you, thank you very much. So 4-step process selection for Alteplase treatment: diagnosis, severity of stroke, exclude bleed, and the contraindication, and give the treatment. You do blood glucose coagulation profile because you're giving a blood thinner, blood count, troponin, and ECG. You do NIHSS as we discussed, and you see all the contraindication like platelet greater than 1 lakh, blood glucose greater than 50, and INR less than 1.7. And there are other various risk factors, but these are the only absolute contraindication where there is a blood in the brain, where you cannot give the blood thinners for such patients. So when the therapeutic measures for the blood pressure comes, that is very important when you're treating the acute stroke. So when you treat the acute stroke, you should, if it is not in the window and you're not thrombolizing, then you keep the blood pressure less than 220 by 120. It depends on you what you want to use for the blood pressure. But when the blood pressure you want to reduce in acute stroke treatment, we are giving the thrombolytic drug, it should be less than 180 by 110. You give drugs like labetalol, that is 10 milligram bolus. You can go up to 40 milligram of it. You can give hydralazine if the pulse is low. You know, labetalol is a beta blocker. It will lower the pulse. If the pulse is low, you can use hydralazine. You can use other drugs like sodium nitroprusside, and there are various other drugs which you can use. So key takeaway: India, 1% stroke happen every 40 seconds, 1 stroke death in every 4 minutes. Unmet need: there is a poor coordination between the authorities and the healthcare, and inadequate number of skilled and trained staff. If you come further to come in this stroke community, then you are most welcome when you do your complete your and you go on to go in such research. The suspected patient assessed by the expert physician. So conclusion to our whole presentation will be that IV thrombolytic treatment is a radical change in ischemic stroke, which has proven to be a very effective treatment, and it has made a huge difference in the form of relative risk reduction and the absolute risk reduction of 5.5%. And we discussed the number needed to treat in such patient, and you harm close to 1 in 100 patients. So favorable outcome for the patient in within the 90 minutes, and benefit is within 4.5 hours, but we will not further wait for the patient. You will treat as soon as possible. But you see, the 20% of the certified centers across world, you see the United States only thrombolizing 8.5% of patient and Canada 8.9, but we are doing 0.1%. You see, we are thrombolizing at least around what I got the data was 15,000 thrombolysis in a month. So which is very less if you see the magnitude of the population in India. So we are doing very less number of the treatment in India because people are not reaching to the hospital and they are not knowing about the treatment in acute stroke. So we know the largest obstacle is time, and time window is very important in stroke. And if you are listening to the talk, this is what is important to treat such stroke within the time window. So thank you very much. Most stroke are preventable and treatable. Stroke need not necessarily disable. Stroke need not necessarily kill. And this is what the COVID time slide is. At this time of challenge, we medical people, or as a community, the worship places were also closed. but the place of healing and cure, hospitals were open. Stay safe and stay healthy. And thank you very much for inviting me for the talk. It was a pleasure talking to you all. Thank you for the patient listening. Thank you. I'll
Thank you
stop
so
sharing.
much, sir. Yeah. That was really a very informative session. It surely added so much to our knowledge regarding the management of stroke. Although we are already running out of time, but sir, is it possible for you to answer a couple of questions?
Oh, sure. I'm totally into it. No problem.
Thank you so much, sir. So our first question that we have received is, what are the general precautions to be taken by an individual who has had a stroke earlier?
So, very good question. Those who had a stroke earlier, what are the general precautions they have to take? It is very clear, just like a heart attack, you have a stroke, you have to take care about your blood pressure, which should be less than 140/90. You have to take about your, if you are having a diabetes, you have to keep your blood sugar into control. You have to keep your lipid profile in control, which have the definite values according to the ATP guidelines. And you have to keep a good lifestyle. But you can live normally. It's not a problem. But these are the precautions, like you have to do the physical activity and you have to control all the risk factors which are modifiable, which I just discussed.
Okay, thank you, sir. And one more question is there. One of the participants has asked, what are the herbal remedies that can be used for the prevention or management of stroke?
Herbal remedies are definitely there should be some, but I'm a very much a allopathic doctor, so I don't know much about it. I'm not the expert who can comment on that, but there are a lot of things which are available, which are blood thinner in those herbal and the Ayurvedic treatment, but I'm totally unaware about it, so I'll not be a right person to answer that.
Okay, sir. Um, can you tell us some counseling points for the management of stroke?
So for management of stroke, as we discussed, the most important thing is time. And you should know when you have not to give the treatment as you are using a blood thinner, which is a very dangerous thing, which can cause a bleed in the urine, which can cause a bleed in the GI. So you should be sure when you are using such important treatment in acute stroke. So treatment is very clear, can be done up to 24 hours. So reach to the hospital whenever you have a stroke. It is 2 days, 48 days. You have not seen a neurologist, you have to see it to know the treatment, the mechanism why you have suffered the stroke, so you don't have the other stroke, right? And if you are within 24 hours, get a treatment and get reverse your stroke.
Okay, yeah, thank you so much, sir. I guess that brings us to the end of the session. I would now request Aishwarya to please propose the vote of thanks. Thank you once again, sir.
And I'm sorry if I have taken a lot of time. It is almost 7:10,
No,
right?
No,
no,
sir.
no, sir,
It's
no issues.
actually, sir, a very interesting session for us, sir, and we are pleased to have you over here, sir. Sir, actually, even I had a doubt, sir. Sir, in like for endarterectomy, like if you compare endarterectomy with stenting, which one will be better? Like, how can you counsel a patient? Because usually they always ask you, like, which procedure is better. So, can you
Very
please tell
good
us?
question. Very good question. When the patient come as an acute stroke, Ashwarya, it's a very important question in the sense when patient come as an acute stroke within 4.5 hours or 1 day, if the large vessel, told you about the middle cerebral artery, if it is a large vessel occlusion, then you go for an intervention immediately. But if there is not a large vessel occlusion and the occlusion as at the small vessel, you have to go for a thrombolytic drug. But to answer this question in the Indian perspective, there are not a lot of place where the interventions are available. If you see the tertiary or quaternary centers, they are not much in India. If you go to the rural area where there is a CT scan available, you should thrombolize even the large artery vessel as a stroke. And you're talking about the neck one, then those are stented, which are soft plaques, and those are done surgery as a carotid and arterectomy where there is a calcified plaque. That is for the treatment of those carotid stenosis.
Yes, sir. I was asking for the neck one only, sir, because
Oh, you're
that's in.
asking for the neck one. Okay, so neck
Yeah.
one,
Yes, sir.
the soft plaques, those who are not having the calcification, they are stented, and those who are with the calcification and the stenosis, but you have to know the critical stenosis. Critical stenosis is greater than 70%. But even if it is not 70% and there is a ulceration, then also sometimes you have to operate such patients so they don't throw stroke higher up again. Thank you for that question.
Okay, sir. Thank you so much, sir. So, like, even though we've almost had a session of 1 hour 40 minutes, like all our participants are still tuned with us. So that really shows that everybody is actually interested into the talk, and it was a great talk, sir.
I'm
Uh,
really thankful to them that they beard us, though they beard all of us for 1 hour 14 minutes. I really thank them all. Be safe and healthy.
Kuldeep, any more questions? Shall I move with the Thanksgiving?
Yes, one question was there. Is it okay if we take it?
Yeah, sure.
Yeah,
We are here for
okay.
that only.
Okay, yes, sir. So one of the participant is asking, confusion is also a symptom of epilepsy. So how do we differentiate between stroke and epilepsy?
Oh, wonderful question. If you have such questions more, you can shoot if people are there to listen, right? So it's a very good question. Confusion can be a seizure, can be a stroke. That is very right. So whenever such patient comes acutely with confusion, we do a MRI for them. In seizure, there will be no damage to the brain, but in stroke, there will be a restricted area and diffusion when we see on MRI. So imaging in acute setting is the important for when they come with seizure.
Okay, thank you so much, sir.
So now I would like to thank our speaker, Dr. Arvind Sharma, sir, for this marvelous and enlightening presentation. All of us gained immense knowledge through this. I'm sure this will be useful for all the families and medical students. On behalf of the whole family community and all medical students, I would like to thank our speaker for the evening, Dr. Arvind Sharma, sir. I'm thankful to you, sir. Even during such difficult times of COVID-19, you delivered such an informative lecture for our family community. Lastly, I would also like to thank all the participants who joined from all over India, and they actually took out time for our webinar. I hope this will benefit all of you during your hospital posting. Thank you so much, sir. And in future, we will like to have such sessions from you, sir.
Thank you, Aishwarya. Thank you very much. We'll definitely, if you want, I will be there next time whenever you want me. I wish all the best to all of you guys. A very good initiative to the Pharm D community.
Thank you so much, sir.
So we'll take a leave. Thank
Yes,
you all the organizers, and we'll see you
yes,
soon.
sir. Thank you.
Thank you. Thank you.
Yes, sir. Yeah, thank you, sir. Shall I close the link, Kuldeep?